Chapter 16, Assessing the Musculoskeletal System. So the function of the musculoskeletal system, it's a complex system that provides support, structure, as well as protection, and it allows the human body to move in all different types of directions and causes a lot of movements. And the picture that you see before you has all of the different types of muscles along with all the different bones. There are about 206 bones divided into two regions, which is the axial skeletal as well as the appendicular skeleton. And then there are different types of bones. You've got your long bones, your short bones, and your irregular bones. And your axial skeleton is the skeleton that holds your neck and your cranium to your body, where your appendicular skeleton are all the other bones, your arms, your legs, your femur, your humerus, your tibia, your fibula, as well as your rib cage. A joint is two or more bones that come together. You have two types of joints, your synovial joints, which have a joint capsule that keeps the synovial fluid in the joint. And synovial fluid is more protective, acts as a lubricant, and allows movement of the joint. An example of your synovial joint is within your knee. So it's a classic synovial joint. And your non-synovial joints don't have fluid. They don't have a joint capsule. And another example of a non-synovial joint may be the cranium. The two parietal bones fusing together is a joint. And there are different types of joints. You've got your fused joints, which are your skull bone joints. Your ball and socket joints, which an example of that is your elbow. Your hinge joint, or rather actually is your elbow. Your ball and socket is more of your shoulder, sorry. You have your gliding joints, your plane joints, as well as your condyloid joints. Plane joints are found primarily in the vertebrae. Your gliding joints are your hands, your wrists, your ankles, your foot. Your hinge joints are your elbow, your finger, your knees, as well as your toes. That kind of open and close, where your ball and socket make more of a rounder movement, more of a grander movement. Your vertebrae consists of 33 bones and cartilaginous segments that compose the vertebrae in the spinal column. And from this picture, you can see you have 7 cervical vertebrae, 12 thoracic, which are in the blue, 5 lumbar, which are in the red, and 5 sacral, which are the purple, and then your coccyx bone. There are over 600 muscles in the human body, and these muscles help to protect our bones, and the muscles are responsible for grand movement. There are 3 types of muscles, your cardiac, your smooth, as well as your skeletal muscle. And it's your skeletal muscle that you have most voluntary as well as reflex control, where your cardiac and your smooth muscle are involuntary muscles. There are different types of muscle and joint movements. You should know these, as actually you should have learned them in anatomy and physiology, but we're going to review as well as use them when we're conducting a health assessment on our patients. You have your abduction, which is just moving a joint towards the center. Your abducting, you're taking away rather. You're adducting, where you're putting it towards the center. So abduct, ABD, you're taking it away from the center. Adduct is you're placing it towards the midline. Pronation and supination, you can use those with the elbow joints. Pronation is a downward movement, where your elbow joint is focused downward, and your supination is your upward movement of your elbow, where you're opening your arms up and out. Eversion and inversion You can do those with the foot where you're everting out, exit. The E is the exit, and inverting is you're pointing the foot inward. These are actually two harder movements to make, especially in the elderly population. Dorsiflexion and plantar flexion. So dorsiflexion is taking your foot and moving it towards the head, where plantar flexion is taking the foot and pushing it like a gas pedal. Flexion, extension. All right, flexion is close to the body. Extension, or extending your arm, is away. And then elevation is moving up and then moving downward. You also have tendons and ligaments. Tendons allow for the attachment of muscles to bones, and ligaments attach bone to bone. So there's an example of your tendons as well as your ligaments. When you strain, when you cause a strain, it's related to straining a tendon. When you're spraining something, that's a sprain of the ligament, bone to bone. There are a number of diagnostic tests that are conducted that tell us some information about how the joints, the bones, as well as more importantly the muscles, are doing, how they're functioning. Creatine phosphokinase, CPK, is an enzyme that increases when muscle tissue is injured. So if someone is injured a tissue or muscle tissue, those levels start to increase because there's more blood flowing to that area. An X-ray assesses bones and bony structures, and those use radiation waves to image bones for any deformities, fractures. Magnetic resonance imaging, MRI, is a more advanced form of an X-ray, I want to say, that gives us more in-depth detail about injury to bone as well as muscle. You also have your CT scans, which assess bones, ligaments, joints, as well as the axial skeleton, and then your DEXA scan, or your bone density scan. And those are more for the post-menopausal patients who are more at risk for bone deformities, osteoporosis. Usually DEXA scans are done postmenopausal every 2 years to determine whether patients have osteoporosis or osteopenia. So we come up to our first question: what type of joints are found in the knees and toes? I'll give you a second to think about this. If you said hinge joints, you're correct. Remember, hinge joints are those elbows, fingers, toes that open, close, flex, and extend. You're performing a musculoskeletal assessment and ask the individual to move their move their right arm towards the midline of the body. And what is this called? So remember, you're adding towards the midline of the body. We are adducting to the movement towards the midline. Which diagnostic tool is contraindicated for somebody who has an implanted insulin pump? And if you said MRI, that's correct. MRIs use strong metallic fields and pulses, and an insulin pump may be affected by that magnetic field. So let's get into our subjective data collection. So subjectively, we want to collect our health history, determine proper functioning of the musculoskeletal system, and it's important for the performance of activities of daily living, your ADLs. Someone comes in with for a focused visit, if they have pain, back pain, musculoskeletal pain, you want to use your old CARTS mnemonic. When did it start? Where is it located? How long have you had it? Type, characteristic or type of pain. What do you use to alleviate the pain? Is there anything that maybe aggravates the pain? What have you done to relieve the pain? What treatments have you used? And on a scale of 1 to 10, with 10 being your worst pain, what have you done to relieve that pain, and what is your pain scale? So you also want to collect a family history and determine if there are any genetic or familial issues. Patients who come in with a family history of osteoporosis are also at a higher risk for osteoporosis. Have they ever had any past surgical history? Have they ever injured the same joint, same body part? Where has that been repaired? Have they gone to physical therapy? What do they do on a day-to-day basis in which it seems as if they overuse that muscle or that joint? So an example of that could be if they are, like for us, for example, if we're constantly in front of the computer typing away, we probably have a lot more pain and discomfort in our wrist and wrist area. What about past medical histories? Are there any comorbidities? Do they have a history of arthritis? Maybe arthritis is younger in the younger population. A history of myopathies, osteoarthritis, RA, which is an autoimmune disease, rheumatoid arthritis, as well as osteopenia or osteoporosis. We want to collect information about their nutrition and their nutritional status, weight loss, or sudden weight gain. And then if they are in pain, we want to ask them to identify the location of the pain, as well as describing the pain. Is there any further pain? Does it radiate? Is it referred somewhere else? And is there any numbness or tingling or pins and needles associated with that pain? And if they can describe it, is it sharp? Is it dull? Does it ache? Does it burn? Does it sting? Is it shocky? Is it intermittent or constant? Is the pain, does it feel hot or does it feel cold sometimes? So we'll have the patient in their own words describe what their pain feels like. We want to further assess pain in the area that they're complaining about. Have there been temperature changes? Usually temperature changes can be related to blood flow or lack of blood flow. The cooler the joint, the less blood flow to that area. Are there any skin color changes? Cyanosis in that area? Is there a bruise if it's a trauma? Is there ecchymotic areas, black and blue areas? Are there signs of inflammation? We also want to identify any risk factors where with gender, female population are more likely to develop that autoimmune disease, rheumatoid arthritis, where in men, osteoarthritis is more common. The older the population, especially in the female population, the more they're at risk for developing osteoporosis, where you have a decreased level of estrogen and you need estrogen for bone development and bone growth. So when estrogen starts to drop, they're more at risk for osteoporosis or osteopenia and then osteoporosis. And then their activity level, are they physically active or do they have a sedentary lifestyle? Do they go to the gym? Do they do, weight-bearing exercises? Do they swim? What do they do versus those who don't are more at risk for pain, in their joints? Cultural considerations include Caucasian and Asian women who are more likely to exhibit bone loss and osteoporosis. So a patient complains, they come in to see you and they're complaining of muscle weakness after spending a week in the hospital. And what is this called? Arthritis, myalgia, myopathy, or muscular dystrophy. If you said myopathy, you are correct. Myopathy is more of a focal or diffuse musculoskeletal dysfunction and weakness. And it could be more acute than chronic. And so, of course, our assessment is going to include inspection of all, the entire body, the joints specifically, palpation We are not going to use percussion or auscultation in our assessment of the musculoskeletal system. It's going to be range of motion as well as strength. So those are the two added ones when we're assessing the musculoskeletal system. And in terms of, collecting our objective data, we want to make sure that the room is quiet, that it's well lit, that we're able to see. We want to allow for enough space, especially if we want the patient to get up, move around, assess their gait, assess their, muscle movements. We want to be able to explain the assessment, have them wear a gown or something comfortable, but enough that we can see their joints. If they are wearing any special devices or prosthetic devices, make sure that they're on and they're functional, such as glasses, hearing aids, and then, of course, as always, performing hand hygiene. We want to incorporate the 5 Ps when we're assessing our assessment of the musculoskeletal system and determining whether there is any pain in that area, any paralysis or numbness, any paresthesia where they're not able to move, any pallor that can, determine whether or not there is adequate blood flow or not. And then, is there any pulsations, or are there no pulses? And that usually is related to pallor. If a joint is paler, there's usually limited or very thready or weak pulses. First thing we want to do is assess their gait. And gait is simply the way they get up and walk around. And we want to make sure that they're in a safe area in order for us to do this, where we have them walking back and forth. We also want to take into consideration any safety issues, their age, as well as the presence of pain when they're walking and where that pain is, and making sure that if they are walking on the floor, that there is adequate footwear so that we reduce the risk of them falling. We would like for them to walk back and forth, and while you're asking them to walk back and forth, you're assessing them anteriorly as well as posteriorly or even laterally. Inspect for any differences in leg swing and arm, and there should be like an alternate movement of their legs as well as their arms, and their inability to control any joints. And ask yourself, if they're using any assisted devices, are they using them correctly and properly? And is that assisted device helping them? So the gait length should be about 1.5 meters from foot to foot as they're walking. Again, legs should be swinging. There should be equal leg and arm swing, and the arm should swing contralateral, so opposite. It should be smooth, it should be even, and they really shouldn't have to use anything to help them move. No cane, no walker, and their back is straight up. They have good posture. They're also able to maintain balance. They're not limping, and the motion is expected. What you would find abnormally is limping, alterations in their movement, moving forward, ataxia, where they're not able to move a joint, or their joint movement is with tremors. They're shuffling, or they're shuffling their foot. They're not lifting their foot off the ground, or when they put their foot down, there's a foot drop. And this is an example of what foot drop looks like. It's usually related to the peroneal nerve, or damage or trauma to that area that's preventing that foot from gliding up and then stepping forward. We also want to inspect their posture and determine the alignment of the muscles. Looking at the back is very important. So we want to look and determine, what their posture looks like when they're walking. Is their head centered? Are there any alterations in balance? Is there an inability to ambulate or stand on their own, or do they need assistance? And then one thing you also want them to do is have them sit in a chair and then get up from the chair and see how even they distribute their weight and how even they're able to get up. Ask them to position their shoulders and head forward and normal flexed, and then have them rotate from side to side. have them tip their head to the right as well as to the left. Is there pain, or does one side flex more than the other side? And they're usually, if they have neck problems or neck pain, you will notice that there's more difficulty putting their head more towards one side than the other. Then you're going to ask them to flex forward, extend, and then hyper extend, where they're extending their head all the way back. Further assessment of their posture, we're going to look at their spine. We're going to palpate also their vertebrae in each individual vertebrae, asking them to bend forward, bend to the side, and then bend to the other side, flexing themselves forward, extending themselves, and then hyper-extending themselves. Obviously, with you, they're standing, so they won't fall. And obviously, when they're standing, feet are shoulder width apart slightly, and their head is centered. They're able to distribute their weight evenly on both legs, and they're able to move range of motion, ROM, of the neck and back symmetrically, that one side is not greater than the other. There should be no complaints of numbness or tingling. When we're inspecting as well as palpating the vertebral column, we're looking for any abnormalities. We're looking for issues with scoliosis, kyphosis, lordosis. And I'll show you those pictures in a little bit. And we're going to inspect the alignment by palpating one individual vertebrae at a time, starting from the top, looking for any tenderness or protrusions or pain or discomfort as you're doing that. The column should be straight. There should be no pain. There should be no deviations in the actual plane, the cervical, thoracic, and then lumbar. And you shouldn't find any protrusions or depressions. And so the bottom left picture is an example of scoliosis. The bottom right picture, where my face is an example of kyphosis. And then the top is an example of normal lordosis. And then in pregnancy, lordosis becomes a little bit more pronounced as the uterus protrudes forward. The back has to support that growing uterus. We want to inspect and palpate the upper extremities, looking for any deformities. We're doing the upper extremities. When we're talking about the upper extremities, we're talking about the shoulders, the elbow, the wrists, the hands, the joints, the fingers. And we're assessing for any deformities, pain, tenderness, weakness, inflammation, bulging, changes in temperature. We're using the dorsal part of our hands to assess for temperature. And we're going to repeat the other side. And I always say you want to try to do both at the same time. So if there are changes in temperature, you'll be able to identify that. So for normal findings with the upper extremities, there should be no presence of pain or altered sensation. There should be no deformities. There should be, normal range of motion. There should be no limitation in range of motion with extension, flexion, as well as adduction, abduction, and circumvention. The upper arms, this is kind of for some reason these are opposite, so there should be no forward rounding of the shoulders. Posture should be back and straight. Arms should be straight. There should be a slight bend at the elbows, and the wrists should be in alignment. Abnormal findings, the arms are not straight, or one is longer than the other, or one is not flexed as well as it should be, or there's an opposite in their arm strength. And wrists are not in alignment with their lower arm. We would assess range of motion and muscle strength of the extremities by asking them to push, pull, tug forward. We always want to do an assessment of the range of motion before we assess for strength of that joint and that muscle. So with the shoulders, these are, this is pretty much the shoulder as well as the hips are the two joints that you can do majority of the range of motions that are listed there. Flexion, extension, adduction, abduction, as well as internal and external rotation. And one secret to remember internal rotation and external rotation is for internal rotation, external is above the head, where internal is below the back. E before I. So that's my little secret to you. And so these are examples of all of the different movements that you can do with the shoulders. And then the same with the elbow, really is more so flexion and extension. There's really no hyperextension, adduction or abduction. Flexion, extension, as well as pronation and supination. Pronation with your wrists and your palms down, and then supination with your palms up. But you're really assessing the elbows in that respect. And you're doing that with and without resistance. So again, range of motion, and then a range of motion with resistance. Range of motion, and then range of motion with resistance. So here's some examples of range of motion for the elbow. And then with the wrist, kind of the same thing, flexion, extension, hyperextension, radial deviation, ulnar deviation. So ulnar is near the pinky, so ulnar, and then radial. And it's just a slight movement of the wrist from side to side. And you're doing those with resistance and without resistance. Same thing with the fingers, you're flexing, you're extending, and sometimes you can even hyperextend, and then you're doing that with and without resistance. And then you have your Tinels and your Phelan sign, which are simply tests to determine if the patient is at risk for carpal tunnel. The Tinels is simply having the patient squeeze their wrist and then opening it and then tapping the median nerve that's located right at the center of right at the wrist, right center of the wrist, slightly near the radial pulse. And then your Phelan sign is asking the patient to hold both of their wrists together, and then when, about like a couple of seconds or so, when they start to feel tingling around their finger area, their fingers, the pinky, as well as the ring, and maybe even part of the middle, and down to their wrist region, that could be a positive indicator for carpal tunnel. And those are two simple tests that can be done. Grading muscle strength is also important. Normal muscle strength is at a range of 5, where 4 is they're able to move the joint with some resistance. 3 is they're able to move the joint on their own, but they can't move it with resistance. 2 is they're able to move the joint in a gravity eliminated position where there's no resistance, but they need a little bit of help moving it. 1 is they're able to contract the muscle slightly, but they're not really able to move the joint. And then 0 is pretty much paralysis. They're not able to move the joint at all. You also want to assess the muscle strength of the upper extremities, and strength should be between 4 as well as 5. And there's going to be some slight differences between the right side and the left side, especially, if they're right hand dominant or left hand dominant. So you're going to evaluate your patient who is complaining of elbow pain. What is the correct sequence of this exam? And remember, inspection is always the first one, so by way of elimination, we can eliminate C. Palpation is your next, and then we always said range of motion before resistance. So if you said D, you're correct. Lower extremities is kind of going to follow the same format as the upper extremity, where we're going to assess for any abnormalities, ask the patient to perform specific motions, conducting range of motion activity, and then assessing and comparing the right side to the left side. And so, same thing for the lower extremity. We want to palpate, inspect the lower extremities, and we did part of that by assessing their gait. But with palpation, we are going to palpate the hip, their hip area, their knees, their ankles, their foot, as well as their toes. Very similar to shoulder, elbow, wrist, as well as fingers. And again, assessing for presence of tenderness, depression, bulges anywhere, or any temperature changes. And normal findings should include no pain, no alterations, no deformities. Right and left side should be symmetrical. Weight should be evenly placed on both legs, and hips should be in a neutral position. And then with some abnormal findings, the weight is distributed unevenly. There is there is excessive bend at the knee, and that's to kind of support one side over the other, and the ankle is not perpendicular to the lower leg. We want to assess range of motion to determine strength and limitations, and again, the highest grade is 5, where they're able to move normally and with resistance. And normal flexions of the hip include flexion, extension, adduction, and abduction. And then with the knee, flexion and extension only, although some people can probably hyperextend their knee, and you want to do those movements with resistance. And then same thing with the ankle, the dorsiflexion, and then the plantar flexion. And then your foot, eversion, and then inversion. And normal findings, there should be symmetry from the right side to the left side. The motion should be fluid and without pain. And there should be no pain or altered sensation, no numbness. Temperature should be equal, warm to touch, and their strength should be between a 4 and a 5. And again, as with the right side and the left side, there might be some differences in muscle strength dependent on which side they favor the most.